everyone. Good evening, and thank you for joining us for the Antenatal Shared Care Obstetrics update. My name is Lauren Thomas, and I am CPD Program Officer with Central and Eastern Sydney PHN. I would first like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to Aboriginal and Torres Strait Islander people who might be joining us tonight. At the end of the webinar, the evaluation survey will be available from the chat box and also pop up in your browser, and a follow-up email as well. We really appreciate your feedback. Please complete this so that we can issue certificates of attendance. Today's event has been RSCGP accredited for 1.5 hours of educational activity. To qualify, you'll be required to obviously attend tonight's session, and we'll submit your activity hours on your behalf. We also, 3 Antenatal Share Care points will also be allocated for those GPs in the Antenatal Share Care program. Please submit your questions via the Q&A box, and it will be answered at the end of each presentation. We'll endeavour to get as many questions asked as possible, but please be mindful we have a lot of GPs that are joining us today. We also have some upcoming events. If you're willing and wanting to register, please visit the CESPN website. So before we kickstart today with our presentations, I'd like to quickly introduce Dr Sylvia Lim, who is a specialist GP and sexual health physician at South Eastern Sydney LHD, who's just going to share some information regarding congenital syphilis and syphilis mini audit tool. Sorry, thank you for joining, Dr Lim.
Thanks very much, Lauren. I'm just going to quickly share my screen, everyone. And good evening, and thank you for coming along to this evening's antenatal share care update. So my quick presentation is really about supporting GPs in assessing for more congenital syphilis and the syphilis mini audit tool, which will give you, most importantly, 11 hours of measuring outcomes in your CPD. So I'm here on behalf of CESLID as well as CESPN and ASHM today. So the first thing to know is that the congenital syphilis rates are rising. Between 2022 and 2023, the number have increased from 15 to 19, where previously it was a single digit. The majority is in our Aboriginal and Torres Strait Islander people. And this, in the last 12 months, we've had 6 deaths from congenital syphilis. This is important because it's entirely preventable, 100%. And it's currently on Kerry Chan's radar for us to make sure that we're monitoring and assessing for syphilis in pregnancy. So the New South Wales Health and the New South Wales Sexually Transmitted Infection Strategy is we need to have an increased response to syphilis in pregnancy. We need to eliminate congenital syphilis. Antenatal syphilis screening is now twice during pregnancy, at the first antenatal visit and then again at 26 to 28 weeks gestation. If you have a patient who is at high risk of infection or reinfection, screen opportunistically, preferably at least 4 weeks prior to delivery. And the reason for this is because if we provide treatment with benzathine penicillin at least 4 weeks prior to delivery, the chances of congenital syphilis reduce greatly, maybe 0. Please refer to the Australian Consensus STI testing guideline for Aboriginal and Torres Strait Islander people. In terms of syphilis, basically, it's increased testing frequency. This table is basically to show you that the risk of maternal to child transmission of syphilis is highest in primary and secondary syphilis. So early detection is very important. And then again, repeating that if we are able to treat at least 4 weeks before delivery, the chance of congenital syphilis is very low. However, unfortunately, at least 79% of women were diagnosed late in pregnancy, and 15 mothers were diagnosed with less than 30 days prior to delivery. So we were not able to prevent congenital syphilis in those cases. So now, very excitingly, to let you know about the syphilis mini audit, which is a collaboration between South Eastern Sydney Local Health District, ASHM, as well as CESPN. There's an education package, and we have created a GP syphilis audit tool. The scheduled end date for accessing this audit will be the 30th of June 2025, and it's been accredited for CPD activity up until 2025 triennium for 1 hour of educational activities and 11 hours of measuring outcomes. The QR code link is also there for you to access the website, but otherwise, if you just search syphilis mini audit, it will come up for you. So there are learning objectives, as with all learning courses. But the most important thing for you to know is that once you have completed the mini audit, which I'll show you, once you submit your reflection and evaluation to ASHM, and ASHM will upload your CPD hours. So what does this mean? So after you go through all the videos, you get this really lovely Excel file, which is basically going to be your audit tool. Your first line is going to be offering STI screening to patients. If you complete the patient demographic info sheet and they do their test and you complete the test results, we count that as 30 minutes of measuring outcomes. If you diagnose someone with syphilis and there's treatment and more information is required, you can be allocated 60 minutes for that patient. So in order to get your measuring outcomes of 11 hours, you just need to do 22 STI screenings, including HIV and syphilis, or actually have had, and I hope you don't have, 11 syphilis diagnoses. And what we're targeting is really people of reproductive age who are able to fall pregnant, because we're trying to reduce the number of women who are positive for syphilis and then have the opportunity to fall pregnant. Now, the other history that you're going to need to take is actually provided for you in the line. You can see in syphilis history, in current syphilis, and in syphilis management. And there are prompts along the way. So if, for example, you try to give doxycycline to a pregnant woman, my Excel file will come up in red and flag for you not to do that. And the other important thing is that although you have entered all this data, you do not have to do any data crunching. This summary tab will automatically be present in the Excel file, and the data for evaluation that you need to submit to ASHM is just in that top left-hand green box. You just need to submit the number of tests conducted, positive syphilis test results, and the number of PHU mandatory syphilis notification forms you have completed. All this stuff just happens automatically. So it's a really great audit tool. I'm really glad that my team and I were able to make this up for you. There's also a tab for resources. And there's more resources on the rest of the Excel file sheet. What I want to highlight to you is that the sexual health info link line, 1-800-451624, has a health professionals line that you can use from 9 a.m. to 7 p.m. Monday to Friday. Press 1 for health professionals. And we've got nurses who are well experienced with the management of syphilis who can provide you with initial advice and help you refer your patient on if you need one of the publicly funded sexual health services. In that bottom right graph, you'll see roughly where the publicly funded sexual health services are close to you. Please always feel free to call one of us for advice. We're more than happy to help. So if you would like, please feel free to take a picture of the QR code or a screenshot of this for ways to increase syphilis screening in your practice and get up to 1 hour of educational activity and 11 hours of measuring outcomes. Thank you. And back to you, Lauren.
Thank you, Dr. Lim. We'll also send out the slides to afterwards, so you'll get a copy of those. So if you miss the QR code, you'll receive that in the follow-up email. So I would now like to introduce our GP facilitator for tonight, Dr. Effie Alexandratos, who is one of the RPA and Canterbury Hospital Antenatal Shared Care GP advisors, who will introduce tonight's speakers and facilitate the Q&A. Thank you, Effie.
Thanks, Lauren. And thanks for that great information, Dr. Lim. Fantastic. I'll introduce our next speaker, Dr. Kerryn Houghton, final year trainee in neonatology and general paediatrics at RPA, who will be presenting common paediatric issues in the first 6 weeks. Thanks very much.
Thank you. And everyone, please let me know if anything happens with my slides and you can't see them as I flick through. So I'm going to try to give you a really quick overview of what the first 6 weeks of life might look like and kind of common things that GPs might come across. So hoping to quickly talk about hips, hearts, jaundice, and something close to my heart, preterm neonates. So developmental dysplasia of the hips. So what are we worried about with hips? Unfortunately, this is an area where I can't give you kind of quick and fast answers to, and there's a lot of ongoing research about what we should be doing with hips. So we know that newborns can have normal hips, they can have hips which are dislocated, so not actually sitting in their socket, or dysplastic hips, so hips where the hip joint has not formed properly. Clear risk factors are family history, and really important to note that being female breech is actually quite a big risk factor as opposed to just breech more broadly. Who should we screen and why should we screen is a big question, but the reason why we're trying to screen is to prevent long-term disability. So we're trying to prevent children from having hip deformities, gait disturbances, and arthritis. So we know that early screening leads to increased treatment, but the challenge with that is that early screening doesn't necessarily lead to improved outcomes. So the problem is that treatment can cause complications, and they can be quite significant. So we're talking about avascular necrosis of the femoral head, nerve palsies, pressure areas, and lots of parental anxiety. So the ongoing question we always have is, who should we ultrasound and who should we treat with braces? We know that performing ultrasounds on all neonates leads to increased rates of treatment, but it doesn't actually improve rates of late detection or of surgery. So really what we should be looking at is doing targeted ultrasounds, but that doesn't necessarily always decrease our rates of DDH in regards to late diagnosis or surgery. So ongoingly, we have this issue of who should we recommend for you to screen and who should we recommend for you to refer. And hopefully over the next couple of slides, I'll give you a little bit of an answer to that, but it is still an area that we question day to day here at RPA. So it's a very old slide, it's slightly old text, but really the people who are at the highest risk are our female breech babies, babies where there's a family history, and we're talking about a first degree relative, so not an aunt of an aunt, but a first degree relative, and particularly females who have high risk. So you can see that our breech male babies actually are only having rates of about 2, whereas when we're talking about our female breeches, we're talking about 17%. So ongoingly, we have a discussion of whether or not we should be ultrasounding our male breech babies, and I would say that that's still open to discussion, and we often here at RPA will just ultrasound our female breeches. So we would ultrasound female breeches, we would ultrasound patients who have a first degree relative who had DDH, or if there's an abnormal clinical examination. So it's quite a narrow spectrum of patients that we're ultrasounding, and it's because we're trying to not overtreat. The rationale for treatment is that by placing the hip in the appropriate position within the hip joint, that you will have normal development of the hip joint and therefore long-term good functional outcome. Unfortunately, though, there's no clear consensus about at what degree of ultrasound abnormality we should be starting to brace these patients. And we know that the vast majority, so upward of 90% of babies who have abnormal hip ultrasounds, but not abnormal examinations, will actually end up having normal hips even without treatment. So who should you refer to have treatment? So if a patient has hips which are dislocated and you're unable to relocate, those patients should definitely be referred on to our orthopedic colleagues for assessment and for treatment, and that you should consider a referral or continue to monitor with an outpatient ultrasound those patients who have a normal clinical examination but have suboptimal hip coverage, so less than 50%. Just locally, I assume most GPs are working within kind of the RPA area. Here at RPA, how we follow up our hips ultrasounds is that a couple of the neonatologists follow up the ultrasound reports and we contact families. We don't have a hip clinic, but we will chase the results and contact families with follow-up plans, which is either no further ultrasounds, a subsequent repeat, or a referral onto orthopedics. And if you're ever concerned that you're seeing someone in the neonatal period, so someone at a 4 or 6 week check that you think should have had hips checked through an ultrasound, always reach out and give us a call here at RPA, and we're happy to discuss that and help facilitate ultrasounds in the community. That's hips. Moving up to congenital cardiac lesions, which I think gets all of our hearts racing just that little bit faster. We know that congenital cardiac disease can be relatively common, so we're talking about 4 to 10 per 1,000 live births, but I think the important thing to know is that is all congenital cardiac disease. So that's including our critical congenital cardiac disease, so those neonates who are going to be quite unwell during the neonatal period, but it also includes things like VSDs, which for a lot of patients actually causes no functional impairment and doesn't need treatment. The detection through mid-trimester screening, so with our morphology screening, is about 45%, and whilst that is okay, it means that we are definitely missing quite a number. So what do we do here locally? So we perform pulse oximetry screening, and so that involves putting an oxygen probe on our right hand, but also on the lower limb. We need to do that after the first 2 hours of life, otherwise we get lots of false positives for a variety of different reasons. And we need the saturations to both be greater than 95%, but most importantly for the difference to be less than 3%. Important to note that the vast majority of those patients who have a positive finding on this screening, so 2/3, won't actually have congenital cardiac disease as their primary diagnosis, but will still be neonates that need to be further investigated. And you should see this documented in the Blue Book check that the patient has successfully passed their pulse oximetry screening, and it is standard in most New South Wales health hospitals now. What do you do though if you suspect someone has congenital cardiac disease? And really, I think it's about red flags and knowing when to refer on. An isolated murmur without any other clinical findings is unlikely to be significant congenital cardiac disease. And so whilst we would like those patients referred on either back to us so that paediatrics can have a look at them, or onto our paediatric cardiology colleagues, it's unlikely to be significant or a critical congenital cardiac lesion without these other signs. So tachypnea, hepatosplenomegaly, cyanosis, absence or difficult to feel pulses, particularly femoral pulses, feeding difficulties, lethargy and edema. And I think if we're being honest, the most common findings that we have are around feeding difficulties and tachypnea, and usually those together, and they would be a reason to do an urgent referral onto paediatrics or to cardiology. I've already said this, but I think really important to know, soft murmurs in isolation are unlikely to represent cardiac defects or significant cardiac defects. But when in doubt, always have a discussion with paediatric colleagues and talk about referral to paediatric cardiology. Again, kind of insight into the local service here at RPA, the neonatology team are trained to perform clinician-performed ultrasounds in the neonatal period. Outside of that time, though, we aren't, and we would refer on to our paediatric cardiology colleagues. So luckily, lots of our congenital cardiac lesions will be detected usually through our fetal echo, so the routine screening that's happening during pregnancy. But we do pick up a significant number of those postnatally, and that's through clinical examination, but almost more importantly, our pulse oximetry screening that is universal. Soft murmurs in absence of other clinical sign, though, is unlikely to represent a significant cardiac defect, but you should discuss all murmurs with your local paediatric service to facilitate referral onto paediatric cardiology, and all really about the timing and the need to be seen promptly versus having a routine review at a later date. Jaundice, which is hopefully not something that you are seeing in your GP practice very often, but definitely something that I see day to day here at RPA. So it's really common, it's almost universal in the preterm population, so up to 85%, but is equally quite common in our term population, so about 60%. Most commonly in our term neonates is self-resolves, but obviously our big concern is about not missing babies who have high levels of bilirubin that lead to kernicterus, which can be associated with damage to the auditory nerve and the basal ganglia and long-term neurodevelopmental sequelae. So how do we evaluate for jaundice? Visual inspection, TCBs or transcutaneous bilirubin meters, and finally serum bilirubins. We know that outside of visual inspection, using TCBs and performing serum bilirubin levels can be challenging in the general practice environment. So again, if you're local to RPA and you have a baby who is jaundice, always give us a call. We're happy to help facilitate those because it's obviously something we see every day. And so we have the access of TCBs and quite easy to obtain bilirubin levels. So please reach out. Please don't use a TCB 24 hours after phototherapy is the only other part of that slide that's quite important. Historically, I think we're all taught about Kramer's rule. And whilst I don't necessarily use it in my day-to-day practice because I'm using TCBs, I still think it's an important thing for us to remember in the baby that is having more prolonged jaundice, and particularly in the wintertime when all of our little babies are quite well rugged up, to note that you only need to have a serum bilirubin of about 100 to still look jaundice on your face. So I think if you think a baby looks jaundice while it's still all bundled up, make sure you undress it, because if it doesn't have any signs of clinical jaundice below the neck, it's unlikely to be significant. But again, if in doubt, always give us a call. We're happy to have a look and a chat about these babies. Timing of jaundice, really important. So hopefully no one in the community is seeing the pathological jaundice within the first 24 hours, even though we're doing a lot of early discharge. Hopefully we're not discharging those patients home for them to be seen in the community, but I'm sure it happens at some stage. But I think what you're more likely to be seeing most often in GP practices is our physiological jaundice, which in the term baby goes out to 14 days, or in the preterm out to 21, and also prolonged jaundice. Pathological jaundice in the first 24 hours, we get very concerned about in the nursery, and that's because these are babies who have jaundice levels which can quite rapidly increase, and they can become critically unwell quite rapidly. Again, I'm hoping that these are not babies that you're seeing out in the community, but if you have a baby where we've documented that they've had rhesus disease or ABO, they've probably had a pretty intensive treatment of phototherapy with us in the nursery. Physiological jaundice usually isn't clinically apparent until after day 3. It should peak between 5 to 7, and then it should resolve by day 14. But I think we all know that we see lots of babies floating around in the community that have prolonged jaundice, so jaundice after day 14 in a term baby or after 21 in a preterm baby. The challenge with prolonged jaundice is that it always needs to be investigated. It is commonly not anything that is pathological, but we really need to make sure that we've investigated it appropriately and that a diagnosis of breast milk jaundice, which is quite commonly the cause for us, really just needs to have everything else excluded before we get there. And so you can see a lovely picture of some different baby poos over there in the corner, which is to remind us all that really one of the first steps we need to take in anyone who has prolonged jaundice is to ask about stool colour. And if we've got patients who are having stools which are 1, 2, or 3, which is that top row, so acholic stools, those are babies that need to be quite rapidly investigated and referred on to paediatric gastroenterology because we're worried that those babies might have biliary atresia. Another important thing to always consider is that if we get down the line of all the investigations, it's no longer recommended that we stop breastfeeding in babies who we've diagnosed with breast milk jaundice. This will just resolve in time by itself, and really important to continue to encourage and support breastfeeding in these babies. This is a diagram showing kind of the common causes or spectrums of what prolonged jaundice can be caused by. And the thing that I think all of my neonatology colleagues are really worried about is about missing biliary atresia, which you can see is a significant proportion, but it is a condition where time really matters. And that's one of the reasons why we would say always investigate prolonged jaundice. And so really the time matters is really about what is our likelihood of success with the native liver, so either going on to have a procedure to help with drainage of bile or actually going on to transplant. And so we know that if we don't detect these babies early, and what we currently talk about is within the first 100 days of life, the chances of these babies having adverse long-term outcomes from this increases dramatically. So if you have someone who has prolonged jaundice, investigate them. I know that's probably not practical a lot of the time in your rooms. So please reach out to your local NICU or paediatric service so that we can help facilitate further investigation and we're not missing biliary atresia in the community. So what would we do for investigations? So physiological jaundice is obviously our most common. So we want to know what is the baseline bilirubin. We always want to have a look at the full blood count and the blood film. And this is to confirm that we don't have any signs of hemolysis. We also want to look at the blood group and DAT, so making sure that there's compatibility, and in appropriate populations, looking at G6PD screening as well. For prolonged jaundice, yes, we want to look at the serum bilirubin, but really what we're worried about is what is the conjugated component, what is the conjugated fraction? And really, if the conjugated fraction is less than 20% of the total or less than about 30, that's agreed to be normal. Anything higher than that, we're quite concerned about biliary atresia. We also check LFTs. Historically, everyone had always recommended performing formal TFTs, but you can follow that up through newborn screening. Although in all honesty, it's often easier and simpler to just collect repeat TFTs rather than chase up the lovely staff at newborn screening. And then finally, always important to exclude infection or sepsis. And the most important thing to do as a first step in the well-looking baby for that is to exclude a urinary tract infection. I really like G6PD. It's something that we see quite commonly, and so I think it's really important to always have this in the back of our mind. So don't forget it. It can cause kind of prolonged, severe, and sometimes just quite protracted jaundice, which can be a little bit tricky to manage, but also really important to know that it's a lifelong condition, and so we need lifestyle modifications so that these people don't end up in a hemolytic crisis. It is X-linked recessive, and so most commonly it occurs in boys, but important to remember that as a female, you still can have G6PD. It's just much less common. This is a huge list of all of the things that you need to avoid if you are someone who has G6PD. And there's a number of really good fact sheets, but even though I'm not in this health service, I would say that the one that's produced by Western Sydney, which you can find online by Googling Western Sydney LHG G6PD, is probably one of the best. It's a beautiful plain language summary with information about G6PD on the front, and then the second part is all of the things to exclude/avoid, and has some nice pictures as well, which is really helpful for families. So take-home message is that whilst persistent jaundice in breastfed babies is usually benign, it's really important that we investigate prolonged jaundice to make sure that we don't have a pathological cause, and in particular that we're not missing biliary atresia. That should be considered, especially if you have an elevated conjugated fraction and that time really matters. Finally, please don't encourage cessation of breastfeeding in babies who have prolonged jaundice, even if we determine that it is breast milk jaundice, because the jaundice will just resolve with time and we should be supporting breastfeeding. Alrighty, finally, and I think I'm probably doing even better for time than I anticipated. I'm finally just wanted to do a last little slide about preterm neonates. I think we often in the silo of tertiary level care really keep our preterm babies close to our chests for quite a long time and probably exclude our GPs to their detriment. But there's a lot of evolving evidence around the preterm baby and the effects on the kidney. And so that's something that we would really love our GP colleagues to help us out with. So we know that if you've been born preterm, you're low birth weight or growth restricted, you have increased risk of adverse long-term renal outcomes. And so we would really love your help with, once we transition these babies out of the closely linked care through NICUs, if you could help us by doing yearly blood pressure and urine dripstick monitoring for these patients, so that we're not missing early signs of renal impairment, and so that we can consider early referral on to paediatric nephrology services, or as they age to adult nephrology services, so that we can be considering early intervention, so that we hopefully minimize these long-term adverse renal outcomes. I did a rapid fire through that, so I apologize if I was speaking really quickly, but more time for questions, I guess.
Thanks a lot, Dr. Kerryn. Someone has quoted you back saying, when you reach out, who do you mean?
So I guess it depends on where you are. So here at RPA, if you're local to our network, and in all honesty, that would extend out to babies who are probably local to Canterbury Hospital, we are always really happy for you to contact us via switch. So particularly during business hours, if you call RPA switch and you ask to speak to the neonatology fellow or the NICU fellow, we are very happy to talk GPs through anything that's happening with their newborn babies. And I would say it's not infrequent that we don't get a call. And one of the most common calls that we get is help with investigating jaundice, because like I said, it's something we're really well set up to do, but I know can be quite tricky in private practice, especially if your pathology collectors aren't used to collecting blood from newborn babies.
Okay. There's a series of questions about the hips. That we've got like a GP health pathway that suggests we screen a little bit wider than RPA. So, you know, is yours RPA specific, your guidelines?
Yeah, so this is what we do specifically at RPA, and I guess I presented that more for anyone who's seeing a patient at 6 weeks, and you're thinking, oh, I thought that they would have had a hip ultrasound. So quite specifically to us, we're trying to kind of narrow down who we're screening, and that's really about the research around treatment potentially causing adverse outcomes, and also not wanting to have increased parental anxiety. So I think if you're outside of the RPA area and you're the first person that's seeing this patient for some hip surveillance, you can definitely follow the New South Wales policy as it stands. But if you get a baby who's been born at RPA, you might find that we have not ultrasounded them, and that's our local policy here.
And do you recommend scanning at RPA, or like do we use our local radiology?
So we here at RPA scan everyone through our local service, and part of that is because we don't have a hip specific clinic. So because we scan everyone within the RPA radiology department, it just means that no one is missed for their hip screening. So it comes through to a couple of the neonatologists here, they're reviewed, and then we provide feedback to families about where to go next. But I would say that lots of outpatient radiology departments are very competent and confident at performing hip ultrasounds. We just use our in-house service so that we don't miss hip ultrasounds.
Okay. Other questions related to the blood pressure is, you know, is it the more preterm, the more follow-up, and for how long do we follow up?
So this is an evolving area of some evidence. And so I would say the more preterm you are, the greater your risk of having a long-term adverse outcome in regards to your renal function. But we're talking about any baby who is growth restricted. So even a baby who's born at term, who was small for gestational age, does have an increased risk. So we are seeing all these babies quite closely in the first year of life. So we would be confident that we've seen them in the first year of life. But after that, ideally, we'd want yearly blood pressure and urine dip screening, ideally through till they're 18, and then kind of discussing where they're at from that stage. Hopefully they've not had renal dysfunction by that stage, and we can probably stretch out the frequency of that. But ideally for the first 18 years of your life, you get a urine dip and a blood pressure every year. We know that that is very challenging, and taking a blood pressure off a child's quite tricky. So even if we can have a urine dip alone, that would be great.
Is that something that will be flagged on discharges coming through?
Yeah, so we're hoping that it will start to. It is a relatively new discussion that's filtering through to our junior medical officers. So I think it's something that is often missed off discharge summaries. But if it is missed off the discharge summary, hopefully you will receive it in the outpatient letters of when we're seeing babies, that will send a reminder for that. So I'm hoping it'll start to be a bit more widely distributed, but at the moment it probably isn't, if I'm being honest.
Okay. Another question about jaundice, where we think it's breastfeed jaundice, but it's sort of on the baby check at the GP. When would we consider a blood test?
So I think if you have jaundice outside of the 14 days in a term baby, or outside of the 21 days in a preterm baby, that you should at the minimum be doing a serum bilirubin with a conjugated fraction. Because if you're getting a very low total bilirubin, but particularly if you're getting a low conjugated fraction, it's unlikely that it's anything sinister that needs to be further investigated. In saying that, and I know I said like reach out to your local service, but if facilitating blood tests is going to be quite tricky, most paediatric and neonatal services will have a way that we can organise outpatient bloods, that we can kind of facilitate the child and the family coming in so that we can perform those bloods.
Okay. These questions are coming thick and
kind of
fast.
rapid
Thanks,
fire.
guys. So a question about a sacral dimple. How do we refer? What's our concern with these?
Yep. So for a sacral dimple, again, we're trying to do less and less investigation. And so we talk about simple sacral dimples. And so one that is quite close to the anal verge. And we usually talk about 1 to 1.5 centimeters. And if you can see the base, and you really do have to get right in there and part those butt cheeks with a nice bright light to have a look for the base. So if it's close to the anal verge, so within 1.5 centimeters, and you can see the base, those don't need any investigation. If you feel that you can't see the base, or it's further away from the anal verge, those should be ones that you organise an outpatient spine ultrasound for. And I would say even most of those that do have a spinal ultrasound, the spinal ultrasound is normal, and then they don't need any further follow-up. If you are concerned that if the ultrasound comes back abnormal, then I would be referring on to neurosurge through one of the 2 children's hospitals for advice.
Okay. The blood pressure checks are concerning the GP.
I know, everyone, I can see it so much.
And so, getting a cuff, what if we don't have one?
Yep.
Be happy with just the dipstick?
And so I guess what we would say is like the gold standard and ideal situation would be that we'd be having a blood pressure and a urine dip. But as a paediatric trainee, I know that it's not fun to chase a child around a room with a blood pressure cuff, and then you're not going to get an accurate reading anyway. So I think if there's difficulties with cuff size and actually performing it, even a urine dipstick would be really helpful. I can see there's also comments about like what is the age threshold at which we would call preterm. And so really we're probably talking about babies 36 weeks and below, with the exception of those small babies that are born after that. So if you've got a baby that's got a very low birth weight, those babies would still be at risk of having renal dysfunction long term, but really it's babies born under 36 weeks, and your risk increases, as it does with everything, with decreasing gestation. So the baby born at 23 or 24 weeks has a much higher risk of having long-term problems with their renal function than a baby who's born at 35 or 36 weeks.
Okay. And is there a good resource for us GPs for normal blood pressure per age, like to look it up? Is it?
Yeah, let me just, I'm pulling back my memory. I know that Up to Date has a fabulous table resource that has kind of the 95th centiles for blood pressure at every age. I think there are some better resources, but I know that the Up to Date table is very simple and quite easy to use. But I can have a bit of a think and I can get back and send something through if I can find something that's a little bit easier to use.
Yeah, a lot of the GPs would like the slides. Is that
oh yeah,
a
definitely.
copy can be made? Yeah,
definitely.
That's great. I think we've answered a fair whack.
I can see there's a comment about can we try to get GPs copied into the HIP ultrasound letters. Let me add a little note and I'll talk to our admin who sorts that out at the moment. And I can see there's some for people who are kind of outside the area about murmurs. Really, I think the big thing with murmurs is outside of the immediate neonatal period, you're going to be hard pressed to find a neonatologist who's going to feel comfortable scanning a heart, even though it's most likely not anything too significant. And then I would reach out to the 2 children's hospitals and refer through paediatric cardiology there. If you're having trouble, because I know that system doesn't always work smoothly doing referrals there myself, is if you speak to the paediatric registrar at your local hospital, they're often able to help you with those kind of behind the scenes systems issues that you might come to.
Someone's asking about vitamin D supplementation for breastfed babies.
Yep.
I'm not sure about the context there.
So we're now providing families with education and an information sheet on discharge if mums have vitamin D deficiency to supplement those babies on discharge. And again, if I can find a copy of that resource, I can email that through to you guys so it can be distributed as well.
Another question about G6PD. Does it need to be rechecked later?
No. So once it's confirmed that you have G6PD deficiency, you've got G6PD for the rest of your life, and that is fine. And it's just all around educating patients so that they communicate that with any of the healthcare practitioners they're involved with, but particularly with their GP, so that they're not going to be prescribed a medication that is not recommended for patients with G6PD. I would say the other big thing we find is the use of mothballs, particularly for camping and ski gear, is always a fun discussion. And every so often we have a bit of a run where all the kind of food providers promote flava beans as the new great health food, and then we have a run of problems there. So they're probably the most common things I think people run into is either medication inappropriately referred, mothballs, or people chowing down on flava beans. So avoid those.
So there's a GP who struggles to get the femoral vessels on, squirmy 6-weekers. Do you have any tips?
Oh, femoral pulses is always a fun thing. I think it's about trying to have the baby as settled as possible. And I must say, when we're teaching our trainees baby checks, we talk about everything being opportunistic. So if you have a baby that is already kind of quite settled at the start of your exam, the 2 things that you really need to do with a settled baby are feel the femoral pulses and listen to the heart. Everything else you can deal with a squirmy or unsettled baby. So I'll say, if you can, try to prioritize your femorals and your hearts. Otherwise, unfortunately, it's just a bit of an exercise in patience for both yourself and for the patient. So you can try to get the parents to hold them, but I know as they get chunkier around the 6-week mark, trying to get in and feel the femoral pulses can be tricky if they're being held. The other thing I say to people is also think about your anatomy. And often if you have the legs nicely adducted out, the fat rolls will kind of move out of the way and you're better able to actually get your fingers in there and feel the pulses. But it is a challenge. All of us seem to struggle about it.
You've got to do it when their eyes are open, right? Check their eyes.
Oh my gosh, it's everything. Like, it's all a challenge. I think I also put a big thing out about this, like me being worried about not missing a pathological cause of prolonged jaundice. And I guess it's all about, if you think that if the baby is mildly jaundice at like 14 days, that's totally fine. You don't need to go out and chase all of those babies. It's those babies that you're worried are quite yellow at, 14, 16, 17 days. Those babies really need to be investigated to check that the bilirubin's not too high. And the two options are doing a TCB, which I often find is that my eyes have overread how high their bilirubin is. And I don't think I can count the number of times I do a TCB, and I'm shocked that someone's Billy is probably only about 100 and I thought it was about 200. But if in doubt, you do need to do a heel prick to make sure that we're not missing an elevated conjugated Billy.
I have a question about imaging hips. Is there a particular age where an X-ray might be superior to an ultrasound? Because, a hip dysplasia might be picked up, later in life.
Yeah, and so really we're talking about outside of the neonatal period, and I have to look this up again, but I want to say once you're talking after kind of 6 months, it's starting to be that an X-ray is going to be superior to an ultrasound. I guess the challenge is we're always hoping that we don't miss those babies, but we know that we do. We know that there's children who get missed either through, having had ultrasounds anyway, or falling through the cracks of screening, or never having any risk factors. But I want to say it's from 6 months. You obviously don't get the dynamic imaging that you do with ultrasound, but it's once the femoral head starts properly calcifying, they don't get quite as good quality of ultrasound images, and that's when we move on to X-rays.
Okay. I think we've pretty much gotten through them. Kerryn, you did really well.
Apologies, I sped through my presentation, but I think the questions is probably more helpful.
Okay, one's just popped up. Is the degree of proteinuria significant?
Yeah, and so what I would say is that if you get proteinuria on a single dipstick, then the first thing that I would do is organise for the patient to come back and repeat it. If you're having persistent proteinuria, and I would say the 1+ is probably fine, but I think if you're talking about persistent 2+ proteinuria, then that's someone who's worthwhile reaching out to the paediatric renal team and speaking to them. The reason why I'd say is initially repeat it is that you definitely can get a degree of proteinuria during periods of illness. And I assume that a lot of the time when you might be seeing someone in your GP room, it's because they have a concomitant upper respiratory tract infection, for example. And in those cases, the debate is, do you have proteinuria because you're sick, or do you have proteinuria because you're a preterm baby that has abnormal kidney function? So I'd say first step, if you're getting proteinuria, make a plan to repeat it. And then if you're getting persistent proteinuria 2+ and more, then refer on to renal.
And last question, what type of kidney disease is it that the prems get?
Yeah, so the problem is a little bit multifold. So it's one that they have less nephrons to begin with, and you have less nephrons because you've been born early. You then create kind of suboptimal quality nephrons in the first few days after you're born. So you have a total number that is less than someone who's born at term, but also some of the ones that you've made are a bit dodgy, for a lack of a better term. And then unfortunately, we then pound you with a whole lot of medications that are nephrotoxic, with good intentions, but still not great for your kidneys. So it's really, the problem is about they get hypertension and renal impairment because they have a failure really of the number of their nephrons. So they always are starting from a bad place. And so they're just not making enough nephrons, really, is the problem. So it's not necessarily like a specific type, but it's at their increased risk of hypertension and chronic kidney disease because of a lack of nephrons.
Interesting. We'll have to watch this space. Is there research at RPA or?
So we're not doing anything about it at the moment. If anyone wants to read, so there was quite a big international study called AWAKE, which was an international based study. And there's an AWAKE study that's being run in Australia at the moment as well. Really just looking longitudinally at these babies after they're discharged into the community.
Fantastic. Thanks for a great talk. Lots of great practical tips. And thank you for being so speedy. Amazing.
Oh no, all good. Thank you.
All right. If our next speaker is happy to get going, we might move on to the next speaker. I'd like to introduce Dr. Sylvia Lim-Gibson, who is the Director of Clinical Services in the Perinatal Infant Mental Health Unit at Sydney Local Health District, who'll be presenting on perinatal mental health. Thank you very much.
Thank you for inviting me to speak. Can everyone hear me? And unfortunately, I had some tech problems, so Lauren will be sharing the slides on my behalf. Thank you. The brief I was given today for today's talk is to talk about an approach to perinatal psychosocial screening, go through the screening tools, and to discuss the management of perinatal depression and anxiety. I'm sure you appreciate that that's quite a big talk, so I'll focus a little bit on psychosocial screening because I think it's a requirement, it's a state requirement, but people are not always very clear what we're doing and why we're doing it and what to do with the results, and have a very small section on an overview of the management of perinatal depression and anxiety. Thanks. Next slide, please. So just to recap the range of mental health problems that can occur in the perinatal period. So of course, people can have a relapse of what they already have. So a relapse of pre-existing disorder, depression, anxiety, eating disorders, bipolar, schizophrenia, other psychosis. Or they can have an onset of new illness. And this is a time when there is a peak incidence of these illnesses coming for the very first time. Depression, anxiety, bipolar, and of course, postpartum psychosis. Sometimes people haven't come to it with a pre-existing diagnosis, but they not been people who've had the easiest kind of life or not coped incredibly well. So they have what we call high trait anxiety or emotional dysregulation or a tendency to substance misuse. And when I started in perinatal psychiatry 15 years ago, I probably would have said, you know, I'm a perinatal psychiatrist, I never see anyone with substance use disorder. And I've rapidly had to upskill as our population demographics change. So the one thing, unfortunately, that young Australian girls are catching up with young Australian men is their level of substance use. So sometimes they don't have what they regard as problematic substance use, but it becomes a problem in the perinatal period. Next slide, please. So focusing on perinatal anxiety and depression, just recapping that it is very common. So 10 to 15% of women will suffer perinatal depression through the pregnancy or postpartum, and remembering that the peak prevalence is in the third trimester of the pregnancy and 6 weeks postpartum. So it is as common to be depressed in the pregnancy as it is in the postpartum period. And there's a tendency to persist if untreated. So it's not really the blues and not a transient phenomenon. And these days we call it perinatal anxiety and depression because there's a recognition of the continuity and the commonalities of symptoms across the antenatal and the postnatal periods, and the coexistence of anxiety and depression. They're really like flip sides of a coin. And in this space, because it's perinatal, we need to consider the maternal and infant comorbidities. Next slide, please. Thank you. So just a quick recap on what does perinatal anxiety and depression look like. Well, it looks like anxiety and depression, but often the symptoms are referential to the baby and to their situation. So in terms of the physical symptoms, often people complain of not sleeping. How do you look at not sleeping? When the baby doesn't sleep, they often complain of being unrefreshed in their sleep or not being able to sleep when the baby sleeps, fatigue and motivation. They might have lots of physical symptoms like feeling weak, dizzy, numb, or breathless. Overwhelm is probably one of the most common symptoms, like probably most of the depressed women on our ward will complain about being overwhelmed, and our psychologists and OT spend a lot of time discussing with people how to manage this phenomenon that they describe as overwhelm. The difficulties making decisions, feeling hopeless or pessimistic about the future, not enjoying things. They have a sense of failure and hopelessness that is really often focused around their parenting. They're not parenting well. They don't know what to do. The baby prefers other people to them. And lots of anxiety symptoms, again, often referential around the baby, thoughts of panic, thoughts of fears of harm to the baby, of either causing it, I might cause harm to the baby, is this the right thing to do? Or for allowing it to happen, I may forget about this and then something bad may come, or I can't prevent something really bad. And often it's associated with avoidance behaviors, like sometimes you see babies with very flat heads because mom will not put them on the ground because they will not pick them up, will not allow them to play because there's a lot of avoidance at the interaction with the baby. Sometimes you see babies that may not have progressed to eating soft foods or puree foods because mom is so fearful of them choking that it seems easier to just keep giving them bottles. And obviously that has developmental implications. Next slide, please. Why do we care? Because perinatal anxiety and depression not only affects the woman herself, but the baby. So we've talked about, we know why anxiety and depression is important in treating it for the patient. It tends to persist, it causes suffering, it has impacts on physical health, and therefore in this situation on obstetric outcomes. And of course, there are risks of maternal suicide and infanticide. Acknowledging that in the developed world, maternal suicide is the leading cause of maternal mortality, not because it's higher in Australia and the UK than anywhere else, but because we're so good at managing the medical causes of obstetric mortality and not so good at managing the mental health, that suicide becomes the leading cause. On the baby, think about what that means for a baby if mum is depressed. There's an association with poorer infant care, including non-organic, failure to thrive. We have evidence that the children of mothers with untreated perinatal depression have poorer cognitive performance at school age. And this is because we now have increasing evidence. We understand this a lot more now. We've known this for about 20 years. We understand this a lot more now because we know that in this time, there is, the baby is understimulated. All the kind of neuronal connections that need to be made in this very crucial first or second year of life, not being able, because mom is depressed and unable to provide the adequate environmental stimulation and to assist in their development. There's an association with behavioral difficulties and hyperactivity in children and adolescents. And of course, that infant relationship, there's the impact on that parent-infant and eventually the parent-child attachment relationship. Next screen. Next slide, please. So, perinatal psychosocial screening, what is it? Why do we do it? So perinatal psychosocial screening refers to that practice of that series of screening tools that is conducted as per kind of mandated by New South Wales Health on women booking in to have their babies through public antenatal services. I make that point because we have very little inroads to the women that book in the private system to do this, and we've been doing this for 15 years and we still don't really have a lot of advice on that. But why are we doing it, and why is it now mandated, not just in New South Wales, but it's now being mandated across Australia? It's one of the commitments of the federal government. Because we know that there's a clear temporal relationship between pregnancy, childbirth, and perinatal anxiety and depressive symptoms. We have a good knowledge base of the risk factors that are involved, so we sort of know what risk factors we should be screening for. Apart from that, these are otherwise healthy women and their families who are in regular, predictable contact with existing network of health services. This also, the actual screening and asking of psychosocial questions in the perinatal period of these women validates and gives permission to the women for the way they're feeling. We know that not every woman sees this as a rosy time, and this validates and gives them permission, and it tells them that good mental health care is part of good maternity and perinatal care. It is using a screening tool is a quick way of eliciting information. It has limitations though, because I guess people will put what they want on a questionnaire. Sometimes the question is not interpreted exactly the way they want, or being kind of thought of as quite distant on a piece of paper. They may or may not answer truthfully. And obviously nothing beats our clinical skills and our skill for eliciting information. But what is key is that practice nurses, GPs are key to this process. You're the trusted health professional. You know this patient, you know the family, you know the context. And I think it avoids the stigma of a mental health label. People don't necessarily want to engage with mental health professionals, but they're mostly happy to engage with GPs and child family health nurses and practice nurses. Next slide, please. So just a reminder, I use this in almost every talk I do, but the 1 in 5 women that have an episode of perinatal anxiety depression, most of them are cared for in the green sector. So the mild to moderate and the moderate to severe, some of them are looked after 90% in the primary care sector. PIMS teams, public mental health services, and of course the mother baby unit really only look after the pointy end. They're extremely complex and severe for some reason, who are unable to recover through most of the care provided in the primary sector and need to dip into specialist care. All right, next slide, please. So what is perinatal psychosocial screening and what are we screening for? So the first one is symptom screening. That's the Edinburgh. What the Edinburgh is looking at, it's a test. Are you anxious or depressed? And then there are whether it's the antenatal risk questionnaire, which I think some of you will use, or the obstetric psychosocial questionnaire, which is used at RPA, and then screening for domestic violence and substance use. So that one, you're screening for the risk factors. And so there's 2 types of screening going on. There's diagnostic screening and there's kind of risk factor screening. Next slide, please. So that's what the psychosocial screen looks like. I think over the next few slides, if you can just scroll through the next 2 or 3 slides, that's what it looks like. Just to remind you guys. And that's the version that's used at RPA. And then the next one, the ANRQ. Next slide, please. Here. This is the one that's used through the COPE website. It is used, I think, for those working in the southeast end of the PHN. The big difference, I guess the first lot that we looked at incorporates some of the social history that sometimes gets asked by midwives, such as, did you plan this pregnancy? How was the last pregnancy? Those are kind of incorporated within that framework. This one has a question on the woman's relationship with her mother, which is the big difference between the ANRQ and the other questionnaires. It's all picking out for different risk factors, but by and large, all the other questions are the same, such as, have you had a period of depression? Do you have supports when you go home? Have you had any stresses? Are you generally a worry about order in your life? Those questions are the same. And the questions about kind of childhood trauma and abuse are also in both of those screens. Slide, please. And this is the Edinburgh Postnatal Depression Scale, just as a reminder. This is a 10-item questionnaire. It's very easy to score. It's 0, 1, 2, 3 or 3, 2, 1, 0. So you can read the question and you know which way it scores. And question 10 is a question on self-harm. Next slide, please. All right, so you've done all the screening on the woman that's in front of you that you've booked in, or has just had a baby and is, you're now doing the postnatal check. What next? I guess it's understanding the information. So I made the point between what does the Edinburgh pick up, which is anxiety and depression, and what does the ANRQ and the social questionnaires pick up, which are the risk factors. If there's an illness, you treat the illness. You might review the treatments for what might be stable illness. So they may have reported in the questionnaire that they've had a past history of an anxiety and depression, but they're okay. So you might want to review that and go, okay, things are going really well. What kind of treatments are you on? And if that's enough. I would remind people, I guess, at this point that in the third trimester, due to kind of the fluid shifts in pregnancy, if they're stable on whatever medications they're on, psychotropic wise, it may destabilize in the third trimester. So to keep an eye out for that. The role of sleep disturbance in destabilizing their illness needs to also be considered. So thinking about keeping a really good eye on sleep. And sometimes it's worth a conversation, particularly if they have quite a serious mental illness, like bipolar or OCD. It might be worth saying, do you think it's time you linked in with your previous psychiatrist? Or do you think I should refer you to someone? You haven't seen anyone for 5 years and it's been great, but maybe you need to link in with someone now. Next slide, please. Okay, so looking at the results of the Edinburgh, I'm going to spend the next kind of couple of slides just saying, what do you do with the Edinburgh? What do the numbers mean, and what do you do with it? So it's a well-validated tool for the detection of postnatal and antenatal depression in community-based populations. It's a 10-item questionnaire. It's simple and it's quick to administer face-to-face. It's important to know that it's asking about feelings in the last 7 days. So it's just kind of in the last 7 days, doesn't work out how they felt 6 months ago or 3 months ago, just the last 7 days. Question 10 is a question on self-harm. So if you're asking a question, you need to know how to manage it. When you screen something, you need to know what to do with what you pick up. So you need to have some idea of, what are the practices that you have if you pick up someone telling you that they're very suicidal. We live in very multicultural Sydney, and it's important to know that EDS is translated and validated in a number of languages. Just a proviso that the actual validated cutoff scores are somewhat different depending on what language and culture group that you're using them on. Next slide, please. So scores for community sample scores between 10 to 12 are considered to be scores that you should pay some attention to. A score of greater than 13 indicates the need for further assessment for a clinical major depressive disorder. Between 10 and 12, I think John Eastwood has done sort of some studies together with Brian Barnett and the Homes and Neighborhoods team, that is actually a risky kind of thing. It indicates that something may be going on. So what do you do with a 10 or 12? I would say go back to your psychosocial screen, look at the other risk factors, because often it's about cumulative risk factors and whether there's anything you can do about those risk factors. So if they're identified, for example, that social isolation is a factor, then maybe starting to refer them to kind of community resources and groups for support. If there's a serious relationship problem, then maybe steering them in the direction of relationship counseling or supports in that. So, kind of targeting the risk factors. I would also probably, knowing that the scale is asking about the last 7 days, is say, look, what's been going on recently? A common phenomenon is people have been feeling quite sick in the first trimester of pregnancy. They're still feeling sick when they book in, and feeling sick makes people feel quite miserable. So that can also, in and of itself, be responsible for the elevated EDS. I'll check in supports, what supports are in place, who can you reach out to, and to just let them know, that there are resources out there. Too low an EDS is one of my big bugbears. An EDS of 0 is not a good sign. If you read the questions, most people have had over the last 7 days some points at which they've had some emotional blips. And so an honest rating of the scale should not yield the result of 0. So question 10 pertains to thoughts of self-harm, and a positive answer requires further exploration and possibly considering a referral to mental health services if you need it to manage that acute risk. Next slide, please. So if you get a question 10, how do you explore question 10? First thing is check that the question is understood. So maybe a question, and for people, if English is not their first language, sometimes that question gets misunderstood, and we probably encounter it in an antenatal clinic several times a week where it's just that. Sometimes women become fearful in pregnancy that they might trip over and therefore harm the pregnancy, leads to a miscarriage, and they might score yes on that question because they're fearing accidental harm to themselves. Then I would probably, if we've kind of excluded that it's a misunderstanding and they didn't mean to say that, then kind of a little bit more about what's the persistence of the ideation, the intention, the degree of planning. All the usual questions that we ask when we pick up someone's suicidality. Make an assessment of how quickly you need to refer them. Probably bring in the partner or the next of kin, and consider contacting the emergency mental health line on 1-800 or referring someone to the emergency department. If we assess that the risk is really high. Thank you. Next slide, please. Picking up perinatal anxiety and depression. This is a very, very general slide on how do we manage that. I guess the first thing to do is perinatal anxiety and depression comes from a whole range. Like most people will have a mild or a moderate sort. By the time, I've seen them, whether in private practice or in a public practice, they're probably moderate to severe. And then when they get an admission to the mother-baby unit, they're really quite severe. I guess I would say that the kind of admissions that we would get to the mother-baby unit would be either people who have a biologically severe episode of perinatal anxiety depression, or it's actually got psychotic features, so it's more postpartum psychosis or relapse of bipolar, or they've got perinatal anxiety and depression, but kind of co-mingled in with lots of trauma, emotional dysregulation, severe OCD. So they've got some kind of complicating factor. So I guess the first thing is to assess in the patient in front of you, where does this person with anxiety and depression fall? So you need to know the symptom severity, the risk factors, whether there are psychotic features associated. And part of informing you of where they fall in that spectrum of risk and severity is looking at the associated psychosocial risk factors. So you would go back to those psychosocial screening questionnaires. I think you get discharge summaries that are printed out from the hospital. If the midwives have done those screens, that I think is really useful. I often look at them just to say, all right, it's a quick screen. Did they say they were a warrior? Did they say they've had depression before? Did they had a history of abuse? Is there domestic violence? What was their level of substance? It's a very quick screen. And then using that, I would kind of hone in on which factors I should need to explore in that consultation. And then assessing the risk. Is making a point that we've talked a little bit before about assessing for suicide risk, but risks in the perinatal setting are risks to self and risk to infant, risks that are direct and risks that are kind of indirect or inadvertent. So are they getting so distracted they're not, or so depressed they can't actually get to feeding the infant? Are they, is the infant kind of at risk of neglect? Or actually is the infant subject to kind of risk of direct harm? So if they feel like this baby doesn't like them, this baby's purposely making them feel, kind of purposely crying to make their life difficult, is there kind of malevolent thoughts like that attributed to the infant? Sometimes people will say, I really, really love my baby, but I don't think my baby loves me, which is kind of a worry. I guess for me, one of the biggest red flags is I don't worry about my baby. My baby's fine, but actually my baby doesn't need me. My baby's really well taken care of by grandma or by my partner, because it's not a very far leap from that to I don't need to be on this earth anymore. They're severely depressed because my baby's already taken care of. So you can see that sometimes the assessment of risk is a little bit more subtle in this space. All right, so once we've got those risk factors and we we can stratify whether we are kind of in a mild to moderate episode or the moderate to severe. If you look at the kind of things I've got on managing that, you'll see that they are the same, except that if we think there's enough severity, then I would jump to adding medications and actually treating the illness with a medication, as well as doing the managed psychosocial risk, managing the sleep, increasing the supports, and doing the psychological therapy. So everybody gets that. But the difference is that if they're severe enough, then I think we need to shortcut a consideration to medication. I guess the reason for kind of making that decision and jumping into it is because things change rapidly and evolve rapidly in this time. People, the relationship, the parent-infant diet is so affected by what is happening. We don't really have time to waste in terms of waiting for someone to trial a psychologist for 6 weeks, 8 weeks, 12 weeks, and then start thinking about a medication. When you start a low dose, it's going to take a month to kick in. Then we think, no, they actually need something stronger. So then we take another 6 weeks. That's a very long time in this infant's life to be without a mother that's able to be responsive, intensive, and responsive. And it's a very long time for this woman to feel like she's not connecting with her baby, not able to do the things that she wants to do. We recently got an admission to the mother-baby unit for somebody who was, by the time she came to us, about 32 weeks pregnant and severely depressed. So she had been in Westmead Hospital for several weeks because she presented to the ED saying that she wanted to kill herself and the infant that was growing inside, the baby that was growing inside of her. I guess what highlighted to me the story was when she came to us, she said, I have an untreatable illness. I've had seen a few doctors and they told me that because I'm pregnant, they can't really treat me. She had one SSRI. She didn't respond to that. She was started on the second one. And when I saw her, she was on 25 of Zoloft because she thinks she felt Lexapro or something. And they moved her on to a low dose of Zoloft. And she was still very depressed. And by the time her depression had progressed so much, she was kind of suicidal and also one kind of infanticidal, as in she wanted to destroy the fetus going inside of her. And anyway, it was a good news story because we made the jump straight to the vaccine. I dialed up the dose fairly quickly because we're an inpatient unit, and also because in the third trimester, I felt like we were chasing our tails with doses and fluids. And she recovered and was well enough to be discharged home to her supports and had her baby near her family supports, which was quite a distance from Canterbury. So that's what I have for you today. I didn't specifically address the issue of psychotropics and pregnancy because that's a whole other talk in itself, and I think it would be a bit much, but I'm wondering if there are questions and really happy to discuss around any questions that people think might be helpful.
Sorry, I'll unmute. There's been a fair number of questions. There was a comment about a paediatrician who studied sleep deprivation, and if you could repair the sleep of the mother, 80% or thereabouts got better. Would you care to comment?
Yes, thank you for the question. So yes, sleep deprivation is a form of torture. And yes, I think being able to give the mum some sleep, I think I've put in all the management bits that manage the sleep. So sleep management is really important for women that are at risk of a mood disorder. I talk to them a lot about managing sleep in the third trimester of pregnancy, particularly, and not allowing sleep to deteriorate. So being preventative in not letting sleep deteriorate. Even if it means we give low dose Restavit or something to get them to sleep, I think it's really important because sleep disturbance in itself can precipitate an illness like a mood disorder. In the postpartum period, if you can restore sleep and they improve, that's amazing. And in the mother-baby unit, we do whatever we need to do to get this woman sleeping, and we don't we often don't start anything else because we want to see if just sleep restoration is going to improve things. So yes, big advocate of sleep.
Yeah. And the comment is the baby slept. So if we have magic fix for the baby sleeping too.
Yes, yes. It's often grandmother, or partner. On our ward, it's the nurses.
Okay. Look, GPs are strung out with time and resources. So, are there any sort of non-drug treatments, any psychological tools, or are there online, apps or services that you would recommend or, think about?
Yes, so I think there's some good kind of perinatal counseling services. So if people can get themselves onto Gidget or something, they can get their 10 sessions with a psychologist. So that's starting the question on a high level, like psychologist that you can refer to. There are, like the Smiling Mind app is a good app. There used to be an app called Mind the Bump. It's been a while since I've looked at it, but there's a few apps that take women through relaxation, through thinking about the baby. In terms of websites for information, both Panda and Cope and Gidget have got great websites with stories. It guides people to simple things that they can do for themselves to help them feel better. So those are kind of other things that you can direct people to.
Yeah, and they're all validated, the online services. Yeah.
Oh, sorry. There's also an online CBT that's specifically for perinatal, and that's through the St. Vincent's. You know how they have the online one for the non-perinatal. They have one that's specifically for perinatal.
Okay.
It says it can be done in 3 sessions. I recommend people do it on 6 because it's quite content heavy.
Okay. And there's a question about SSRIs safe in pregnancy and breastfeeding. Like, is there a preference? Do you have ones you use, more than others?
Yes. So that's the 5 minutes answer to that is, in general, yes, SSRIs are safe. In pregnancy and the postpartum, the risk of that, of course, in pregnancy, nothing is completely, no drugs is the most safe. I guess the risk of SSRIs in the 3rd trimester it has a slight increased risk in persistent pulmonary hypertension, which is a tiny but not invisible risk. SSRIs, they impair clotting, which again shouldn't be a risk. But if you have a massive PPH, and that could be considered one of the factors, and it does increase the risk of GI bleeds. And of course, it increases the risk of the baby having a poor neonatal adaptation syndrome, which is they are quite jittery, difficult to feed, difficult to settle. That usually resolves itself in 3 to 7 days, and most babies are looked after at the bedside and not in the NICU. So that's SSRIs in late pregnancy. SSRIs in lactation, yes, they are way under 1% detected in breast milk, so it's not really a problem. Is there a preference? We use a lot of sertraline. I think it's one of those things that's become a self-fulfilling prophecy. Perinatal cicatrice, we use lots of it. We're familiar with it, we're comfortable with it, and we give it to people. My one thing I would say is, if someone is stable on a medication, think very hard about why you're going to swap it. My first line would be, if they come to you and they're already pregnant, then if you think about fetal development, they're probably at least 6 weeks, 8 weeks. The story might be over in terms of trying to change them. Secondly, rapidly ceasing a medication can cause more problems than not rapidly ceasing it. MotherSafe is a very user-friendly, free hotline that you can always refer people to, and you can call yourself for a consult. And sometimes you may swap to something that doesn't work, and it's not necessarily any safer.
Okay. The questions are just rolling thick and fast. Sorry, doctor. Any other ways to manage sleep if we've got long waiting times for sort of places like Karatani and Tresillian?
Do you mean pharmacologically or?
Yeah, I'm not sure. You know, it's just everything is, you know, long waiting times. Yeah.
And not necessarily. I think people need to understand what Tresillian and Keratani offer. And if you're going to book in for the residential, you need to understand it's not necessarily, they don't take the baby off you and let you sleep. So if you're looking for sleep restoration, that's not necessarily the answer.
Yeah. And what about pharmacological?
So pharmacology, well, I start in pregnancy, I use rest of it. I start with a quarter of a tablet. What often worries me is someone's already taking like 25 of rest of it for nausea and they're still not sleeping. So people that I've seen that have needed more than tiny doses. So CNCs I've worked with and nurses have learned to quarter tablets because, you know, my kind of dosing, I would say 6.25 of quetiapine, 1.25 of olanzapine. Yeah, I start really tiny. And often I think if sleep is a real problem and it's not in the context of a serious mental illness, often the small doses help. So what starts to worry me, if you call me and go, I've given this person 25 of quetiapine or 10 of olanzapine, they're still not sleeping or they're only sleeping for 2 hours and then I start to worry. I think we need to then consider, is there a more serious illness going on like a postpartum psychosis?
Okay. What other questions? There's a comment about paroxetine safety. Would you use that postnatal? Are there other ones?
I'm not a good person to ask because I'm not a paroxetine fan in the first place because it's quite hard to come off at any time. But yes, paroxetine got its safety rating kind of changed. I think the bigger question is, I wouldn't start someone on it, but if someone came on it, then I would probably give them all the kind of risk benefits and say, look, there were, at one point, there was a signal, and these things are just signals. We don't have RCTs on medications in pregnancy. There was a signal that it may be responsible for cardiac defects, and it got its ratings changed, and this is what's happening. But you've got this, you've been stable on it for a really long time. And it really depends when are you having that conversation. As I said, if they come and they are already pregnant, then it's maybe not the best time to say, well, are we going to swap things over if they've been really stable on it? If they come and they go, I got started on this when I was 18, I'm really depressed during my HSC and I was better and I'm now 30 and I feel really well, I'll be saying, you know what, do you want to try it? Come off it. Or at least if things occur, then let's think about starting something else like sertraline that we might be slightly more confident with. The rules would be then I would wean it very slowly. I would work out with somebody, what does it look like when you're sick? And when would we agree that you restart treatment? So if I stop going to work, if I can't concentrate on my studies or whatever it is, well, this is the time I would need to start on something and I'll come back to you.
Outside of SSRIs, something like valdoxin, is that being used in this group of patients? Is it safe?
We don't know anything about it being unsafe. We don't know anything about it being safe. We have very, very little information, so that wouldn't be the one I would be reaching for.
Okay. GPs are asking for baby sleep clinics. Do they exist in as far as you know?
Clinics that make babies sleep?
Yes.
I don't think so.
There
aren't like night nannies that train your baby to sleep, like super nanny for babies.
Mm-hmm.
They're very expensive, but some patients have said, it's worth it. But the whole family has to sleep as well. So they go off, they turn off every light in the house. Everybody needs to follow the rules of that super nanny.
Fantastic. They just asked for a recap on the places you mentioned for postnatal depression. So Gidget Foundation.
Oh, yep. Gidget is a good place. There are a number of good specific perinatal psychologists around, kind of big practices that you can go on, like Maternal Connections is one that comes to mind. Tresillian does a little bit, Tresillian, if you go into Tresillian, you will get screened for depression and you might get a one-off assessment from their VMO psychiatrist. So I think it really helps for women in that mild to moderate category, because sometimes as part of that, they might start an SSRI and then refer you off to outreach. And then the Tresillian clinician comes and visits and supports both the baby as well as the mum in that. So that's also a really good thing if you can get in. Obviously, you could think of the private St. John of God. If they have private insurance, they have outpatient P&D programs. So that's worth, because if they've already paid for their private insurance, they get that, I think, at a minimal cost or free, depending on their level of insurance. And the online things, think about using the Panda website, the Gidget website, Cope website. People get a lot out of those peer-supported websites where they listen to people's stories and people put in tips about what they should do. And then the perinatal version of the This Way Up, which is the online CBT program.
Okay. And there's been a question about whether we could get your slides copied and maybe these websites summarized to us.
I'll work on the summary, not on the slides, but definitely, Lauren, I'm very happy for you to share the slides. And actually, I've got my email on the first slide, so I'm happy for people to put questions and queries.
Okay. I think we've covered most of the questions. There's a lot of repetition about getting, babies to sleep better, but I think that's beyond the scope of this talk, to be honest.
Absolutely, yeah.
Yeah. So I thank you very, very much for your time and for answering all these questions. And thanks to all the GPs who've attended. I'll hand over to Lauren for some housekeeping, if that's okay.
Thank you very much for inviting me. Have a good evening.